Thank you for joining us with this conference, the ninth conference for Department of Clinical Oncology at Science University. And we are waiting for your presentation about the new approaches to metastatic hormonal receptor positive breast cancer. Okay.
Thank you so much for having me. I will just pull up my slides. 1 minute, please. So today I'm going to be discussing approaches for managing metastatic hormone receptor positive breast cancer. And you just had an excellent talk reviewing a lot of these data, and I'll try to put it in perspective also to how we're viewing things currently in the US for thinking about strategies in this particular setting. So I think, as you all heard, CDK4/6 inhibition has really revolutionized our approach for treatment of metastatic disease, knowing that ER-positive cancers do preferentially overexpress cyclin D or have loss of P16. They do tend to have overactive cell cycle functions. And so inhibition of CDK4 results in halting of the cell cycle at that G1S transition point, really resulting in cellular senescence, which we think will eventually potentially result in apoptosis. And as you all just recently saw, we've seen many pivotal studies conducted in the metastatic setting, adding CDK4/6 inhibition to endocrine therapy, either in the upfront endocrine sensitive population or in the endocrine resistant population. All of these studies have demonstrated benefit from the addition of CDK4/6 to endocrine therapy. What we've seen in the first-line setting is very consistent benefit across these pivotal studies, really with hazard ratios that are remarkably the same, around 0.55. So in essence, doubling PFS in that first-line setting, again, very consistently across all these trials. So what we have is approval for all of these agents, whether it's palbociclib, ribociclib, or abemaciclib, all in the first-line setting, as well as we'll discuss in the endocrine refractory setting in combination therapy. The one unique approval is for abemaciclib as monotherapy in a pretreated population, though as we'll get to, this is not something currently commonly utilized given the current treatment paradigms. One of the challenges, however, that we've seen is very different data with regard to overall survival. And so what we've seen is that the ribociclib studies, so you can see here, MONALEESA 2, MONALEESA 7, MONALEESA 3, all of these trials have demonstrated remarkable improvements in overall survival. We've, however, seen that neither PALOMA 2 nor PALOMA 3 demonstrated survival benefit in combination with endocrine therapy and palbociclib. So I think this was a bit surprising to many of us, and we'll get into the details for maybe why this could be. We have seen survival benefit with abemaciclib in the endocrine refractory setting with fulvestrant, and we'll discuss, we've also seen interim data with regards to overall survival in a first-line population with abemaciclib. And while not technically statistically significant, I think many will agree that it does reflect very robust clinical improvements that I think are quite clinically meaningful. So why is it that we're seeing differences in overall survival between these different trials? We saw these data from PALOMA 2 at ASCO. Again, this is a first-line study of AI with or without palbociclib. And we unfortunately saw that there was no survival benefit, where you see actually very remarkably similar OS data between the two arms. One of the challenges with this trial was it was the very first of the first-line CDK4/6 inhibitor studies to be conducted. And so during the conduct of this trial, in fact, palbociclib received FDA approval in the first-line and subsequent line settings. And during the timing of this, many patients elected to withdraw from the trial so that they could get guaranteed administration of CDK4/6 inhibition. So that meant that those patients who withdrew, many of them did not allow for continued collection of survival data. So this led to high numbers of missing survival data, where you can see in the arm of combination therapy, 13% missing data, and in the placebo arm, 21% missing data. And so I think this has led to many imbalances between the two arms in terms of survival information. And when you look at the forest plot, when you look at the arms where survival data is available at a same rate in each of these subgroups, you actually see that the trend where survival data is available consistently in both arms is towards palbociclib's benefit. But in the arms where there's imbalance in survival information, you see that the trend is no longer present. Again, making some question if maybe part of the reason we didn't see OS benefit was because of this missing information. There was an attempt to combine data between Paloma 1 and Paloma 2. Again, Paloma 1 also looked at letrozole with or without palbociclib. And here you can see now a stronger trend towards OS, particularly when you looked at patients who had a longer disease-free interval of time. So 12 months or greater, where you do see separation of the curves now favoring palbociclib. But I think one has to be very cautious when doing these kinds of analyses, because again, while it was pre-planned to combine data, it was not pre-planned to look at the DFI greater than 12 months for evaluation. So again, maybe one of the reasons there's differences in survival data is this imbalance in survival information that's available, but could it also be that there are differences in patient populations across these trials? So one of the arguments that was made in the ASCO discussion was that it seemed that the Paloma 2 study may have had different numbers of patients with shorter disease-free interval. However, in truth, it was thought that maybe Mona Lisa 2 had fewer patients, but in truth, part of that difference was more definition. So we think of a disease-free interval as the time from discontinuation of adjuvant therapy to time of initiation of treatment in the metastatic setting, and it was defined differently between the two trials. But if you look at that same definition, you actually see that the trials actually had similar numbers of patients with short disease-free interval, and this was pulled from Novartis data on file. And so again, I'm not sure that that actually is the reason for differences in OS. So what else could it be? Here you're seeing that when you look at real world data, looking at palbociclib in combination with aromatase inhibition, you do see that there is survival benefit. Again, this is not from a clinical trial. This is rather pulled, again, from real world information, but it makes you question, is this again an issue about missing data from the Paloma 2 study that again is making it negative if we see real world data is in fact positive? So I think there's several potential reasons here. One, maybe Paloma 2 is really underpowered for survival. When the trial was designed, that was not, we didn't expect patients to do so well. And so the survival expectations were substantially lower. And again, this study was underpowered for OS. We do see that there is crossover that occurred in this trial, but in truth, I think the number of patients who actually crossed over is probably higher than what's been reported. So if you see it's 12% and 27% in each arm, I do think it's probably higher again because many people withdrew consent and went on to get treatment, but they weren't followed. And so the exact number of crossover is probably not accurate in this trial. When we look at the Mona Lisa crossover rates at Mona Lisa 2, it's actually higher than what was seen in Paloma 2. So I don't think we could necessarily say it's crossover that's leading to the failed OS when we have a trial that did report positive OS. But again, maybe it's just we don't have accurate numbers for what that crossover really is. Again, we talked about missing follow-up data as a potential reason. I don't think it's clearly that there's more patients with short disease-free interval given what we've seen now from the data. So, I think we're kind of left with a conundrum because PFS is really identical. So why is it that OS would be different? Again, I think that we can't really explain this. And again, maybe it's biology, maybe it is differences between the drugs that could potentially lead to these differences. And so, if that's true, what about other trials with other CDK4/6 inhibitors, such as abemaciclib? Here we do see data that was just recently presented at ESMO that looked at the second interim analysis for overall survival from Monarch 3. So this was their first-line AI plus or minus abema study. And here you see almost a 13-month difference between the two arms in terms of survival. And while this was not statistically significant, so it did not yet meet OS, you can really see pretty significant separation of the curves, which to me suggests that we might meet a statistically significant OS. But even if not, I do think this is pretty clinically meaningful to have over a year difference in survival at this interim time point. We do anticipate final OS data being available next year, and so we'll have to wait to see if that officially crosses statistical significance. I think the other important thing to realize, and we don't have, I think this is a question a lot of my patients ask is, well, what's the probability patients nowadays actually will remain on first-line AI CDK, out many years? And so you can see, actually, it's very nice that Monarch 3 actually updated the PFS data, because you can see at 5 years, almost 30% of patients are actually still on their first-line therapy. And so this is pretty remarkable to see. I think we all see it clinically, but I was curious to know what that actual number is. And it's actually quite substantial to see that this is really changing the trajectory of patients' lives, which is pretty incredible. So I think in the first line setting, again, the only agent we have OS data for technically right now is Ribo, but Abema to me does seem to have clinically meaningful OS differences. And, when you look at the sort of pre-treated populations, you do see, again, Ribo has OS, Abema had OS, Paloma 3 did not. But again, we must be very careful, because here the trials were very different, where Paloma 3 allowed patients to have had prior chemo and any number of prior lines of endocrine therapy. So it's much more heavily pre-treated than the other two trials. So here again, this is another piece of information that I think is leaving us a bit puzzled, is we are seeing differences with survival data in the metastatic setting with these different agents. And we're also seeing differences in the adjuvant setting, where we have not seen benefit of palbociclib in the adjuvant setting with PALLAS or Penelope-B, but we have seen benefit with abemaciclib in the adjuvant setting in Monarch-E, and we are awaiting data from ribociclib with the adjuvant NATALEE study. So I think, again, this is leading many people to feel like there may, in fact, be differences between these drugs, but we have not had head-to-head comparison data to date. There is one trial that has initiated called Harmonia, which will actually compare the CDK4/6 inhibitors head-to-head, specifically comparing Ribo and Palbo, but it is doing so only in a subset of patients. So it's only doing so in the HER2-enriched population. So the trial takes upfront patients, gets PAM50 profiling for those 15% or so of patients that end up being HER2-enriched. They then get randomized to get Ribo or Palbo with their endocrine therapy in the upfront setting. This was really based on data that we had seen previously presented, looking at the Mona Lisa combined analysis, suggesting very robust improvements in both PFS and OS in the HER2-enriched population, where this was not seen with palbociclib in their retrospective analyses. And so suggesting that there may be bigger benefit for Ribo in this particular population. So again, interesting that there will be some head-to-head data, but important to remember it is just in a specific PAM50 subtype. So what should we be actually doing? I'd say at this point in time, again, the only agent in the first line setting we have no OS benefit for is ribociclib. I do think the Monarch 3 data is very clinically meaningful, and I think abemaciclib is also an alternative first line agent. I do think the way we're picking therapies in this first line setting is really driven by toxicity profiles and trying to personalize that therapy to the individual patient, as was brought up by our previous speaker, which I think is quite important. Certainly we know ribociclib can prolong QTC. You're not going to use it in someone who has cardiac issues or potential drug-drug interactions. Someone who has underlying GI issues, you're not going to choose to use abema. And maybe in an older patient where you're really concerned about tolerability, maybe you're going to pick palbociclib in that particular patient. So again, you do need to factor in side effect profiles of these different agents, which are quite different, with much more profound neutropenia with Palbo and Ribo, lower rates of neutropenia with abema, but certainly more in the way of GI toxicity with diarrhea with abemaciclib. So while we can say that I think we have choice of endocrine therapy up front, with most patients likely getting ribociclib in the upfront setting, what about the endocrine backbone? my personal perspective on this is it doesn't seem like it probably matters what endocrine agent you're using in that upfront setting, given the data that we have from Parsifal suggesting that in endocrine sensitive patients, outcomes are really pretty much the same with fulvestrant or an AI in that upfront population. So for most of my endocrine sensitive patients, I would select an AI upfront and reserve fulvestrant for subsequent line of therapy. That then leaves us with the question about what to do if someone progresses on their upfront endocrine therapy CDK4/6 inhibitor. And I think the challenge that we're facing is that outcomes with endocrine therapy in this setting are quite poor. We know that from the control arms of Emerald, Trinity, and Veronica, where PFS is really just under 2 months with endocrine monotherapy in this post-CDK4/6 setting. So can we do better than endocrine therapy alone? Could we even think about continuing the CDK4/6 inhibitor beyond progression? We've initially had seen a case series that came out looking at abemaciclib post-palbociclib. Again, this was not a randomized trial. This was just physicians choosing to use abemaciclib post-palbociclib. It was a case series done across several institutions where there were a little under 90 patients that were treated here, and it was used with different endocrine partners, so not all the same. But I think what you can see is that about 40% of people were on abemaciclib for more than 6 months, so PFS of around 5 months. This is much longer than we see with endocrine monotherapy in this post-CDK4 setting. I think making many of us think that this is a viable strategy for select patients. But you do see that there was rapid progression on abema in patients with specific genomic alterations, including RB mutation, ERBB2 mutation, and cyclin E amplification, suggesting that maybe this decision, in my mind, should be genomically driven, where some patients have CDK4/6 resistance mechanisms in place, where this continuation strategy probably isn't rational, whereas in others that lack these CDK4/6 resistance mechanisms, maybe those are the patients we want to think about continuation for. And we've now got more robust data that came out from the randomized phase 2 MAINTAIN study, which looked at this very question, taking patients who got upfront endocrine therapy CDK, randomizing them to switch their endocrine backbone and then get ribociclib with it, or to get a placebo in combination with endocrine treatment. And what you saw was that this continuation strategy with CDK4/6 did lead to a significant improvement in PFS, going from almost 3 months to over 5 months. So interesting that PFS is really pretty similar with ribo endocrine therapy as to what we saw with the abema case series, suggesting that we're getting to PFS that is much more robust than endocrine monotherapy in this post-CDK setting. Obviously, one of the questions is does it matter if you are changing the CDK4/6 inhibitor and which CDK4/6 you go to? The challenge in MAINTAIN is that the vast majority of patients here had upfront palbo. So in essence, almost all patients were changing from palbo to ribo in this particular trial. It didn't look like it mattered what your prior CDK4/6 was when you look at the forest plot with hazard ratios, but I don't think the numbers here are robust enough to make that conclusion. And so I think we need more information to understand if changing CDK4/6 and changing endocrine therapy is needed. Also, I think, again, the critical questions are going to be, are there specific genomic alterations that lead you to benefit from this strategy versus not? Here you can see the ESR1 wild type patients did benefit from continuation, whereas the mutants didn't. But I'll be truthful, I'm not sure that this is conclusive data. First, the numbers here are very small. And in truth, when you looked at the mutations that were co-occurring in the ESR mutation population, you can see that those were imbalanced, where the patients who had ESR1 mutations did have other alterations that could lead to CDK4/6 resistance. And so I'm not sure that it's the ESR1 mutation that was leading to lack of benefit, but rather potentially those co-occurring mutations that may have been driving that potential resistance to treatment. So I think we need more data here. I think this is very intriguing and in my mind does suggest that there's a subset of patients who do benefit from continuation. The question is who are those patients and can we select them? And do we need to switch both the endocrine therapy and the CDK4/6 or just one or the other? And does it matter what CDK4/6 inhibitor you choose? So we'll get more information. We will see data at San Antonio this year from the PACE study, which looked at continuation of palbo post palbo. And so this will be informative because I think this could potentially address if it is a CDK4/6 inhibitor question, because in that trial, patients did switch the endocrine backbone, but they all went on to palbo post-palbo. And so again, if that's a negative study, it would suggest that maybe you do need to do something beyond palbo to make this strategy work. Whereas if it's positive, it may suggest maybe it doesn't matter which CDK4/6 inhibitor you're choosing. So more to come. But then what about other pathways? And we just heard about this from our other speaker, that we know that the PI3 kinase pathway is altered in about 40% of our metastatic hormone receptor positive patients, making this a very attractive pathway to inhibit. We had seen very early data looking at everolimus, so an mTOR inhibitor, suggesting that adding mTOR inhibition to endocrine therapy did improve PFS dramatically. But remember, these were data prior to CDK4/6 inhibitors being standard therapy. We also saw this with fulvestrant backbone in the PRECOG study, again, showing really the same results, irrespective of endocrine backbone, again, showing a benefit with mTOR combination. We also have data, as was previously shown from SOLAR-1, looking at alpelisib, the PI3K alpha inhibitor. And in the mutation population, you saw very remarkable improvements in PFS from about 5.7 to 11 months. But as was pointed out, only 6% of patients had had prior CDK4/6 inhibition. And so that remained a question. The other question was it actually improving survival? And technically, it did not lead to a statistically significant improvement in survival. But what you do see is that there was a numerical improvement in survival with about an 8-month delta between the two arms, which I think is actually pretty remarkable. It wasn't, again, powered for this. This was a secondary endpoint. And so, I do think, again, quite meaningful, and in fact, a 14-month delta in the visceral Mets patients. So I think it is a strategy to think about use of alpelisib here. And again, as was pointed out, Believe has studied this in the post-CDK era, where we have seen that the PFS that you're seeing post-CDK is, again, longer than we would expect with endocrine monotherapy in this setting, ranging from 5 to 7 months. And so remember, when we use endocrine monotherapy, we're really just getting about a 2-month PFS post-CDK. So this is much longer, and I do think is a strategy to highly consider in someone with a PIK3C mutation who's had a prior CDK4/6 inhibitor. The challenge is the toxicity profile, where we do run into challenges with hyperglycemia. About a third of patients with grade 3/4 hyperglycemia. You also see a lot of rash. You see here 10% grade 3/4 rash. I do use prophylactic antihistamines to help diminish that, but again, it is a challenge. Here you can see the data for the prophylaxis with antihistamine therapy, where you do see dramatic reductions in rash. Here you can see with the prophylaxis, 70% didn't have rash. So really important to standardly utilize this. So while I think, again, we have choice of continuation of CDK4, use of mTOR, or use of PI3K inhibitors in that post-CDK setting, one question that has arisen is, what about these selective estrogen receptor degraders? So while fulvestrant is a SERD that is available to us, it has poor bioavailability and has made many of us question if we could do better than fulvestrant. And we've seen the development now of several oral agents. I think the data has been a bit challenging to interpret, though, because we've seen now data from Emerald where elacestrant was compared to endocrine monotherapy, where we did see a statistically significant improvement in PFS in both the ITT and the ESR1 mutant patients, whereas we've now seen data from randomized phase 2s, AMERA-3 looking at amcinestrant, so Sanofi's oral SERD, and Acelera looking at giredestrant, Genentech Roche's oral SERD, where we're seeing differences in outcomes. And one of the challenges when putting these trials side by side is, first, remember AMERA-3 and Acelera were randomized phase 2s. They were not powered to look at outcomes in the ESR1 mutant population as a primary endpoint. Whereas Emerald was a phase 3 that was powered to look at ESR1 mutations as a co-primary endpoint. And here you can see, when you look at the data across these studies, you see, again, Emerald was positive in the ITT, although here you can see benefit is pretty modest, only a 1-month delta here. Whereas in AMERA-3 and Acelera, again, randomized phase 2s, no difference in outcome for SERD versus endocrine monotherapy. Do note that the trial designs were very different because in Acelera, only 40% of patients had had prior CDK4/6. So you see the PFS is much longer than we're used to seeing. But again, remember, the majority were CDK4/6 naive, where here in AMERA-3, 80% had had prior CDK4/6 inhibition. And so you're seeing PFS more in line with that. Here, when you look at the mutation population, though, you see larger benefits in EMERALD. Here you see about a 2-month delta in PFS, whereas in AMERA-3 and Acelera, not statistically significant in the mutants. But again, here you are seeing very similar deltas between the two arms as you saw with EMERALD. And in my mind, suggesting that this is the population that is gaining the most benefit from oral SERD therapy, which is the ESR1 mutant population. I think the challenge that we're facing, though, is that most of us don't like to use endocrine monotherapy. And so if someone's progressed on a CDK4/6 inhibitor, we're usually looking to give doublet therapy. And that was not what was done in EMERALD, Acelera, or AMERA-3. And so what I'd love to see is combination strategies with SERD in the post-CDK setting. And Avera is actually looking at this. This is the combination of giredestrant, so the Genentech Roche oral SERD in combination with mTOR with everolimus, comparing it to endocrine therapy everolimus in the post-CDK setting, which I think is a much more practical application of how we would actually utilize this strategy in this setting. So I think more to come with SERDs. I think they're at least as good as endocrine monotherapy, and I think better in the mutation population. And I think does give patients an oral option. So in the US, we are awaiting FDA review, and it is anticipated that there will be a decision regarding elacestrant's approval by February of 2023. So we may have an oral option for patients. We just will have to see if it will be in the ITT population or if that approval could be restricted to ESR1 mutants. So I think, again, more to come there. And then for our metastatic patients, once they've kind of progressed through endocrine therapies, we are moving more towards chemotherapy strategies. And what we're seeing is we are now seeing availability of antibody drug conjugates in this setting. And so we saw very remarkable data come out from DESTINY-Breast04 looking at trastuzumab deruxtecan in this sort of post-endocrine therapy setting. And in this agent, as we all know, is targeting HER2 and has a topo-1 payload. And when compared to standard chemotherapy among patients who had received 1 or 2 prior lines of chemotherapy, we saw not only improvements in progression-free survival in the hormone receptor positive population that I thought was very dramatic, really doubling of PFS, but also a statistically significant improvement in OS. And so that, to me, is pretty amazing to see this difference where we are doubling time for patients who would have otherwise gotten standard chemotherapy with this agent. So I think, again, dramatic improvements by selecting those patients who have HER2 low expression. We also have data for another ADC. This is sacituzumab govitecan. This is different in that it targets TROP2 and has an SN38 payload. And while this agent is approved in triple-negative metastatic disease, we had seen early data from a basket study suggesting that response rates with sacituzumab in pretreated hormone receptor positive disease was robust and was around 30%, really leading to the development of TROPiCS-02, comparing sacituzumab to chemo in patients with 2 to 4 prior lines of chemotherapy. So do note this is a very different population than DB04. It is much more pretreated, because DB04 was 1 to 2 prior lines, and this is 2 to 4 prior lines with a median of 3 lines of chemotherapy in the metastatic setting. And despite this very pretreated setting, you do see an improvement in PFS, although modest. It was a 1.5-month delta between the two arms. And we just saw data come out at ESMO actually for overall survival reaching statistical significance with a 3.2-month difference between the two arms, suggesting sacituzumab is not only improving PFS, but also improving OS for these pretreated metastatic patients. So I think should be another standard option for our patients. But there are other drugs in development. I think many of you have seen this agent, datopotamab deruxtecan, or what I call Dato-DXd. This agent is similar to TDXd in that it has a deruxtecan payload, but it is targeting TROP2, similar to how sacituzumab is also targeting TROP2. And while we've seen data for this agent in metastatic triple-negative disease, there is a registration trial ongoing for patients with metastatic hormone receptor positive disease. So similar to TROPiCS-02, they're looking at a TROP2 ADC in the pretreated setting, although this trial is less pretreated than TROPiCS-02. It's more in line with the way T-DXd was studied, in that it's for patients with 1 or 2 prior lines of chemotherapy. So as all these agents are moving forward, I think it's going to leave us with this conundrum of how do ADCs work one after the other? Because we have HER2 low patients, for example, that can get T-DXd, and then we may choose to give them sacituzumab sequentially, but these agents both have topo-1 payloads with different targets. And so how are they going to work one after the other? And how, if Dato-DXd becomes another option, how will it work when it also has the same payload but a different target? So I think we need to understand sequencing and efficacy of the different sequences and how resistance to ADC develops. Is it developing to the target? Is it developing to the payload? And how can we think about utilizing these agents one after the other? So I think with that being said, it's really nice to see how our outcomes for metastatic hormone receptor positive breast cancers have evolved over time, really with CDK4/6 inhibition being the standard. Post-CDK, I'm usually using everolimus or alpelisib in combination with endocrine therapy. In some select patients, I think about continuation of CDK4/6 inhibition, particularly if there's no known mutation present for CDK4/6 resistance. And then I think about going to a line of chemotherapy, such as capecitabine, and then if HER2 low, go on to T-DXd. If HER2 zero, I would then proceed on to sacituzumab. But I would think about also sequencing sacituzumab post-T-DXd in those HER2 low patients. But I do think we need more to come on the efficacy of that strategy. So again, just to summarize, I think all patients should get a CDK4/6 inhibitor in the upfront setting. Well, we have 3 different agents. I don't think we know necessarily why it is we're seeing differences in survival, but given what we have seen, I think ribociclib is probably the recommendation for most patients currently, although I will say abemaciclib is I tend to utilize in select patients as well. And then continuation of CDK4/6 inhibition needs a little bit more work and more data to emerge, but I think can be a strategy for select people. Outside of that, I do think about alpelisib in the mutant patients and mTOR inhibition in the PI3K wild types. And I hope we will figure out how to use oral SERDs, because it will be really important for our patients to have an oral option. But I personally think combination strategies are the way forward in the post-CDK4/6 setting. And then finally, ADCs are here to stay, and we will need to learn how to optimally sequence them. So thank you very much. I appreciate your attention, and I'm happy to take any questions.
Thank you, Professor Sarah, for your presentation that you covered concerning those cases of metastatic hormonal receptor positive. And this session is full of, to be full of discussion, because we have 3 cases. We prepared them from our daily work. They are real cases that we face during our treatment. So I think for the questions, maybe they will be through these cases. And I welcome Professor Iman Fouad. She's the moderator, and Dr. Sharif. He is the speaker for the first case. She is a case of inflammatory breast cancer. I also want to announce that now Dr. Jonathan Strauss, he is Associate Professor of Radiation Oncology. He joined us, and he is with us for any also question concerning the radiation. Welcome. Okay.
Good afternoon to everybody. I am Sharif Hassanin, and I am happy to be with you in our 9th conference. Our challenging case today will be a case of inflammatory breast cancer, tailoring of treatment. Mrs. EH is a female patient, 6 years old, diabetic, with no family history of breast cancer. She was presented in June 2022 complaining of painful rapid enlargement and heaviness of her right breast, with area of redness in the skin and a change in nipple shape. On examination, her right breast, there was generalized enlargements of her right breast and an area of erythema occupying the areola and the inner upper breast quadrant, podorange and nipple retraction, and no definite masses were felt. Regarding her right axilla, a firm mobile axillary lymph node measuring 2 by 2 centimeter was present. Her left breast was normal and her general examination was unremarkable. Her mammography showed increased skin thickening and an irregular area of increased parenchymal density occupying the upper inner quadrant. No definite masses could be seen, no calcifications, and the nipple was retracted. The ultrasound shows the same increased skin thickness up to 7 millimeter with mild interstitial edema, altered retroareolar echogenicity with no masses. The opinion was that breast inflammatory carcinomatosis cannot be excluded for further evaluation. Our first question for our panel: what is the next appropriate breast imaging modality or step for this case? Will you go to contrast enhanced mammography or MRI with contrast, or you go directly to skin punch biopsy? And this is just a reminder of the NCN guidelines mentioning that one of the indications of MRI is the clinically occult disease, but I would like to listen from our dear radiologists.
Good evening. You can hear me. Regarding this case, I would go for a contrast study, whether a contrast enhanced mammography or an MRI, keeping in mind that the inflammation is more on the inner side. So I would go for an MRI to check on the internal mammary lymph nodes. And the MRI in this case, the contrast study in general, is aiming at looking for a mass. When we find the mass, we would biopsy the mass and keep the skin punch biopsy either for the surgeons to do it, or we can do it even with the needle under ultrasound guidance. Even sometimes we go a step further and we insert a clip in the mass, because we usually know that the patient will take neoadjuvant chemotherapy, she will go for a mastectomy, but our colleagues in the pathology department, sometimes they like to have a clip in the mass and make sure that there is a complete pathological response. So regarding the radiology, the steps would be a contrast study, in this case an MRI enhanced contrast study. And then we go for the biopsy from the mass. If there is a mass, we clip the mass, we take biopsies from the axillary lymph nodes. If we cannot find any masses, we can take 4 quadrants random biopsies, and that's it.
Okay.
Thank you.
Indeed, the dynamic MRI examination of the right breast was done, and it reveals an ill-defined non-mass enhancing lesion seen in a regional distribution involving right periareolar and right upper inner quadrant regions, displayed iso-intense signal at T1, mixed high signal at T2 and stir, and exhibiting mild clumped heterogeneous diffuse post-contrast enhancement. A skin thickening and nipple retraction were found. Multiple enlarged axillary lymph nodes showing lost fatty hilum, the largest measuring about 21 times 12 millimeter. And the dynamic enhanced curve show rising curve type 1. In the real scenario, the patient did skin punch biopsy or wedge biopsy, which revealed an invasive duct carcinoma grade 3 with numerous lymphovascular malignant emboli and invasion of skin lymphatics. At this point, I would like to hear from our dear pathologist any comment about this pathology.
Inflammatory breast carcinoma, as far as we know, that it is a clinical diagnosis rather than a clinical pathological. The skin biopsy goes with the assumption of the inflammatory breast carcinoma diagnosis. The lymphatic emboli are actually supportive for the idea of inflammatory breast cancer. Yet if we find it, and we rarely do find it in other lesions and other diagnoses than inflammatory breast carcinoma, they should not on their own per se diagnose an inflammatory breast carcinoma, only in the context of the clinical assumption of inflammatory breast carcinoma. The biology of inflammatory breast carcinoma here is triple negative, as I guess, but this is not a constant biology. It differs from one case to the other.
Okay.
Sometimes we do immunohistochemistry if we are in doubt that these are lymphatic vessels, and it is D240 or podoplanum. It confirms that these are lymphatic vessels that are invaded by the tumor cells. But in this case, it seems that it was not a questionable issue.
But depending on this pathology alone, you cannot document the diagnosis of IBC, and this may be found in any advanced cases of T4.
Not commonly found, but alone it should not be enough to qualify the diagnosis as a pathological diagnosis.
Okay. Axillary lymph node biopsy was done, which revealed the metastatic carcinoma, and immunohistochemistry was triple negative, as you just mentioned. CT scans, chest, abdomen, and pelvis, and bone scan were all normal. Our second question, is the PET CT scan indicated for staging of such case instead or in addition to CT scans and bone scan, especially that in this advanced case, CT and bone scan didn't reveal any metastatic lesions? Can we hear from our dear radiologist about the indication of PET scan?
PET CT is usually indicated in the locally advanced cancer, loco-regionally advanced cancer, and stage 4 and inflammatory breast cancer is already staged as stage 4. So in this case, yes, PET CT would do the job, and we would refer her for a PET CT for distant metastasis.
Okay.
Dr. Sarah, we have a question about the role of PET scan in these cases. Can you give us an idea about the indications for doing it in these cases?
This question's for me. You know, I will say in our inflammatory breast cancer program that we have at Dana-Farber, we do standardly get PET CTs for staging of inflammatory patients, in addition to making sure they have breast MRI. You know, we have found that sometimes we do miss evidence of distant disease in the inflammatory patients, where sometimes you also get contralateral nodal involvement that can be missed with the different drainage patterns in these inflammatory cases. So it is routine at our center to get PET in these patients.
Okay, thank you. We have another question. Also, sometimes we have patients which we find that the bone scan, it doesn't show areas of increased uptake, but when we do the pan CT scans, we found that there is bone lesions, which they said there is one osteolytic lesion which is present, and we want to confirm the presence of metastatic disease. In these conditions, should we rely mainly on the CT scan data more than the bone scan, or what can we do in these situations?
I mean, I'm curious to hear what other people think here too, because I think this is a challenging situation where I do find that, usually I like to see a CT correlate for the changes that I'm seeing on bone scan or PET scan, because obviously, there can be false uptake here with inflammatory changes, osteoarthritic changes, prior injury to the bone. And so, it is a challenge to understand if the uptake is legitimately malignancy or not. And so, I think, again, it's tough if there's no CT correlate to that change on uptake. And usually that is what we're looking for. And if there's any area on CT that does look concerning, obviously we would biopsy to confirm. But if it's PET uptake alone without CT correlate, we usually follow that patient.
Okay.
Thank you. Yes.
I just want to ask the radiologist, what is the value of the PET-CT in a patient with normal CT? Because I think PET-CT, if you can find the lesion in the CT and you couldn't find, you don't know what is the nature. But if the patient has a free CT and the free bone scan, did the PET-CT would add to the benefit or would show any metastatic disease?
Yes, it usually can happen because the CT is an anatomical imaging modality. However, the PET-CT, we add a functional
But
part.
if you couldn't find an anatomical disease, what are we searching for in the PET-CT? I mean, the CT didn't show any lesion. Why do we go for it?
Well, actually,
You answer this question, please. I think PET-CT may show bone marrow filtration rather than CT scan. CT scan, you can see the lytic lesion, but you cannot see the bone marrow lesion, which is very common in this case. And also from therapeutic area, this case is triple negative with M0. She will receive Bembro as a frontline. M1. She's N1.
N1, yes.
N1 disease.
N1.
Okay, she will receive Bembro as a new adjuvant treatment. If the patient is M1, she should go for PD-1 suppression. If CPS score more than 10, she will receive Bembro in the first-line metastatic. So she should be precisely staged because if she M0, she will receive Bembro without testing of PD-1.
Just as Dr. Mohammed mentioned, according to the keynote 522 trial, we all know that now pembrolizumab is recommended in the preoperative systemic treatment of this patient with triple negative pathology. But however, our fourth question, in case of unavailability of the drug, which chemotherapy regimen do you prefer as a preoperative systemic treatment in such case? 4 cycles of AC followed by taxanes, dose dense AC followed by paclitaxel, weekly paclitaxel and carboplatin, or TAC regimen?
Yes, Dr. Sard, can we have an answer for this question about sometimes because of the cost of the drug, we don't have the Pembro for the new adjuvant treatment for these patients. What would you prefer from the regimens as a first line, as a new adjuvant regimen for this case?
Well, I think prior to the approval of Pembro, our standard approach had been to give dose-dense adriamycin and Cytoxan followed by either dose-dense Taxol or weekly Taxol times 12. So either of those approaches would have been our standard approach in a node-positive, triple-negative patient, whether inflammatory or not. And I think, is an effective regimen, but clearly we've shown dramatic improvements in event-free survival from the addition of Pembro to that regimen. And so certainly if available would be preferred. There is data that has looked at non-anthracycline-based therapy in the pre-op triple-negative setting. A lot of that work led by Priyanka Sharma and colleagues looking at the docetaxel carboplatin combination for 6 cycles, actually showing pretty similar rates of PCR to what we see with ACT. And actually even some recent data that she presented from NeoPact looking at that same Taxotere carboplatin backbone and adding Pembro, showing pretty similar rates of PCR as with Keynote 522. And while a single arm study, the EFS was also fairly similar, although patient populations are a bit different. So I think it's intriguing and I think we need more data here. But right now my standard approach is anthracycline-based therapy. But I hope in the future we'll be able to understand if we can think about non-anthracycline-based approaches.
Thank you.
Question 5, do you think that patients with IBC who achieve complete clinical response in the axilla and probably pathological complete response have any chance to evade or avoid axillary lymph node dissection and they can go for central lymph node biopsy?
The question is for Dr.
Surgeons.
Veda. Yes, please.
Can we go for central lymph node biopsy if this patient achieved a complete clinical response in the axilla?
I wouldn't advise in such a case. Inflammatory breast carcinoma, very extensive, locally extensive disease. Even if you achieve a complete response, I would go for axillary clearance. I don't advise this.
Okay. Question 6, if this case received the pembrolizumab in her preoperative systemic therapy and she didn't achieve PCR, do you recommend the capecitabine as a part of her post-operative systemic treatment? Yes or no, or we cannot answer these questions time being and a prospective clinical trial is needed? Dr. Sarah?
Dr. Sarah, about this question we are asking because as we know from the Keynote trial, we don't have, Zeroda was not permitted to be given for these patients, even for patients with partial response. What's your opinion? Can we give for them the Zeroda, or there is no available data about this issue?
So it's an excellent question and one we struggle with because, as you point out in 522, there wasn't an adaptive approach based on response to the preoperative therapy. Everyone who got Pembro pre-op got it in the adjuvant setting for 27 weeks, irrespective of whether they had a PCR or residual disease. But I think our concern is that we know that those patients who have residual disease still, even with Pembro, do have high risk of recurrence. And so we are always looking to see what we should do differently. Obviously, we have data from things like CreateX that have looked at capecitabine in a trial where patients weren't getting preoperative Pembro or preoperative platinum. So it's a very different setting with CreateX, but in that setting, we did see that capecitabine improved both disease-free and overall survival for patients with residual disease. So I'll be honest, our group has been utilizing capecitabine in combination with Pembro in the post-pre-op setting for those patients who are BRCA wild type with residual disease. If they're BRCA mutant, we do think about olaparib Pembro in that residual disease population. We do have safety data for giving combination therapy. There was a trial that had been done combining Pembro in the metastatic setting. There was also a trial one of my colleagues led called the Oxel study, looking at Cape-Nivo in the post-pre-op setting. So I feel like at least we have adequate safety data for this strategy, even though we have no efficacy data here. And I think this is also a space where lots of new trials are being developed because it is where we do need data. And I think one of the strategies that is being pursued here is thinking about using an ADC in this particular population, which I think would be of great interest instead of an approach maybe like capecitabine Pembro, maybe thinking about an ADC here would be even more effective.
Thank you.
Our last question, if this patient finished her treatments according to the Keynote 522 trial, and after 6 months on follow-up, she developed liver metastasis, what is the best systemic treatment option that can be given? Sacituzumab govitecan, or capecitabine, or eribulin? We know that sacituzumab was used only in patients who received 2 previous lines of chemotherapy for their advanced disease, but the good point in this trial that it was used in patients who previously received anti-PD-L1. So do you think that we can use this antibody drug conjugate in this scenario, or the patient must have received 2 lines for her advanced disease?
Dr. Cesar, about this patient, if she has relapsed and she developed the metastatic disease, so what is the next, the best next line for this patient?
Yeah, no, it's a good question. And unfortunately, we do see patients with early relapse post-pre-op therapy who had residual disease. So it is not an uncommon scenario, although we haven't seen it so much yet after 522. I think really in this setting, this patient would have had prior anthracycline, taxane, platinum, capecitabine, and Pembro, and then relapse 6 months later. So you've really just given that patient a ton of chemotherapy and seen a relapse. And so I'm not so excited about the performance of something like eribulin or something like that here, because again, they just saw a ton of chemo and relapsed. And so I would probably use something like sacituzumab here. But I think that, just to put it into, I think this is a little bit data-free because, as you point out in ASCENT, you were required to have had 2 lines of therapy in the metastatic setting, or 1 if you had had an early relapse, but you weren't allowed to be first line. You could have been second line in the metastatic setting, but not technically first line, and this would have been a first line patient. And so we don't technically have data for sacituzumab yet in this setting. There is an ongoing trial that is looking at sacituzumab first line. both with Pembro and one study without Pembro. So for PD-L1 negative versus positive patients, allowing the patient to have a 6-month disease-free interval. And in fact, if you're PD-L1 positive, you are allowed to get re-exposure to Pembro if you relapse 6 months or later. So in this particular patient, I would test for PD-L1. Again, I don't know any data about utilization of checkpoint inhibition in someone who's now relapsed 6 months after it, but I think we would think about re-exposing them if there had been a 6-month interval from last dose of Pembro prior to the recurrence. And so I would want to know the PD-L1 status, and I would think about combination therapy for a PD-L1 positive patient with checkpoint or giving monotherapy without. But again, it isn't approved this way. And so, you'd have to see if you get access to the drug in this setting. And I think the other point is I might also test for HER2 low. I'd want to know if this patient was HER2 1+ or 2+ and not FISH amplified, because TDXD is actually approved for the early relapsers first line.
Any one of the panelists, they want to ask any question to Dr. Sarah about this case or from the audiences? Anybody want to ask any question about this case?
I think there was a question which was not mentioned. I don't know about the testing for BRCA mutation in all patients. It was present in the presentation, but I think we skipped this. Do you think that all patients with triple-negative breast cancer, regardless of her age and their family history, should be tested for BRCA germline mutations?
Yes, Dr. Sarah, what's your opinion about this?
Yeah, my answer to that would be yes, because in this, even look at this particular patient with high-risk disease, you wanted to know if she was a candidate for adjuvant olaparib therapy based on Olympia. And then in the metastatic setting, you'd want to know if she's a candidate for PARP. So really important to make sure all your triple-negative patients who would be candidates for PARP inhibition have undergone testing. And so I do test irrespective of age in these high-risk patients.
Okay. Any question? Yes.
I would like to ask about which you prefer to do PD-L1 testing on the primary tumor or from the metastatic site biopsy?
Excellent question. Obviously, if you're trying to game the system and find the most likely PD-L1 positive result, then you would want to test off the primary, because we do know that rates of PD-L1 positivity do decline from primary to met. And also, even in the metastatic setting, site of testing makes a big difference, right? So if someone has a liver met, very unlikely to be PD-L1 positive, whereas if it's a lung or lymph node metastasis, much more likely to be positive. So, I'll be honest, our group has been testing the metastatic site if they've had a biopsy to make a decision about use of checkpoint. And our rate of PD-L1 positivity is much lower than reported. So we have at our institution, our rate of positivity in the first-line metastatic setting is about 25% using 22C3 CPS10 cutoff, which is lower than the 40% seen in Keynote 355. So, that is one of the downfalls. The problem is we don't know which is a better predictor for benefit here. And so, we again have tested the metastatic site, but if you're trying to get them access to checkpoint, I do think the primary would give you a higher likelihood of doing that.
Thank you.
Dr. Jonathan, can we ask a question about the role of re-irradiation as a patient with triple-negative breast cancer, and she had local recurrence, which is unresectable, and what's about the re-irradiation in these cases?
So I think re-irradiation is feasible in these cases. I think in the setting of an intact breast, of course, we have a phase 2 prospective trial, which is our TOG 1014, which shows some extra fibrosis, but good in breast control. But for a locally advanced kind of unresectable series, we have a few series both looking at safety and efficacy. Although you see things like more fibrosis and rib fracture, re-irradiation in the post-mastectomy setting is certainly feasible. We don't tend to re-irradiate the regional nodes because of fear of brachial plexopathy or significant lymphedema. I will also say that reconstructions tend not to do very well in the re-irradiation setting. And lastly, I'll mention that especially in a really challenging setting, thinking about adding a systemic agent or thinking about adding concurrent hyperthermia both may have a role in disease that's recurred after first line of radiotherapy.
What dose, Dr. Jonathan, you are recommending for these patients for a cumulative dose of radiotherapy in these cases? Does it depend on the field size? That it depends on the effects of previous radiotherapy? And what is the maximum dose that you can give?
Sure. I mean, when it comes to, again, the regional nodes, I'll tend not to do a second time, but to the chest wall, I'll tend to take the whole chest wall to 40 gray again, and then boost gross disease to 50 gray or beyond, and that'll get us past 100 gray cumulative dose. It's better if there's been a longer interval between the two courses of radiotherapy. And having said that, and having, there's literature on this, I've done this 25, 30 times. I really like to avoid it if I can, but the kinds of toxicities you see are, again, our fibrosis, telangiectasia, rib fracture, non-healing wounds. It's nice to have a plastic surgeon on board potentially, but I've never seen anything catastrophic from taking the chest wall to 100 gray.
Okay, thank you. Any question?
Okay, so thank you, Dr. Sharif. Thank you, Professor Iman. And now we will go for the second case. Please, Professor Dr. Hani Abdelaziz as a moderator, and Mariam. Mariam, she's an assistant lecturer, and she will present our second case, which is a luminal breast case. Okay.
Okay, our second case will be about a luminal patient. As we all know that in the last 10 or 15 years, the pattern of treatment of luminal type patients have been completely changed. And now we have not only first or second line for metastatic patients with luminal disease, but we have third, fourth, and maybe fifth or more lines. So our patient will be about a young lady, premenopausal patient. And can we start, Dr. Mariam? Okay, please.
39 years old lady, premenopausal, married with 3 offsprings, ASUICOC performance status 1. Her mother was diagnosed as breast cancer at age of 50, post-medical history, no known comorbidities, surgical history irrelevant. The condition started in August 2017 when the patient accidentally noticed a right breast lump, a lemon size, mobile, with no associated skin nipple manifestation, no axillary masses. Sonomammography at that time, right breast mass 3 times 2 centimeter, occupying the upper outer quadrant with ipsilateral non-specific axillary lymph nodes by RADS 4A.
Okay, if we ask our radiologist, Dr. Ahmed, Dr. Alabna, if I have a patient, a young lady, premenopausal with a mass, a small mass, but the BI-RADS is 4A or maybe 3, what about to go for a further study? It is enough for me to go for biopsy directly, or you recommend to do something like MRI or enhanced contrast mammography, or just to depend upon these results and go for biopsy direct?
According to the sonomammography, if she's having a dense breast, we'd rather go for a contrast enhanced sonomammography or MRI, whatever is going to be available. But regarding that she's a BI-RADS 4A lesion, I would rather also at the same time go for taking a true cut biopsy and histopathology, and if there is something abnormal, to go for tumor biology.
Okay.
Core biopsy from the right breast lesion showed invasive ductal carcinoma grade 2, immunohistochemistry ER 7/8, PR 6/8, HER2 +1, KI 67, 11%. Workup was CTs and bone scan was free, clinically T2 N0 M0.
Professor Dr. Rida, if we have a young patient, premenopausal with clinically T2 N node axilla, clinically, would you recommend to go for sentinel lymph node, or we should go for axillary dissection?
Definitely sentinel lymph node. You have clinically negative axilla and radiologically negative axilla. You will go for sentinel lymph node during the operation. You will do conservative surgery, lumpectomy with safe margin, and sentinel node biopsy. Yes.
Okay. Dr. Gamal, are you worried about this patient because she's young, premenopausal? And the question is, if the pathology is different, can you go for axillary dissection if this patient is HER2 positive or this patient is triple negative, or there is no difference?
triple negative patient or HER2 overexpression in T2, I will go for neoadjuvant before operation. For sentinel lymph node. After neoadjuvant, I will go for sentinel lymph node. Even in T2, I go for neoadjuvant first in triple negative. I know, but it's T2. The T2, I will go for in triple negative, and HER2 overexpression, I would prefer to begin with neoadjuvant chemotherapy. Then I will go for wide local excision and sentinel lymph node biopsy.
Would you recommend further additional tests for this lady before starting treatment?
Okay, now our patient is young, premenopause, and she is T2 in the node clinically. Any further workup for this patient, Dr. Sabri?
I think BRCA testing is important. And before discussion of systemic treatment, she's premenopausal, T2 N0 by imaging and by radiology. So I can challenge.
And she has a family history, first degree relative, her mother with a breast.
So I will go for Oncotype DX for this case, because by guidelines, she may didn't receive chemotherapy in the adjuvant setting.
Yes.
So if I go for surgery upfrontly, I will go for Oncotype DX for these patients besides BRCA, but BRCA will not benefit her in this situation. The Oncotype DX should be afforded for this patient to have either chemotherapy or to have combined chemo followed by hormone treatment.
Okay.
NCCN guidelines recommend genetic testing for any lady with personal history of breast cancer before age of 50 or any age with one or more of first degree relative below age of 50. Her condition was discussed in the MDT and she underwent breast conservative surgery, histopathological report, invasive ductal carcinoma grade 2, pathologically T2N1, 2 positive lymph nodes out of 14, free surgical margins. Immunohistochemistry, ER7/8, PR6/8, HER2+1, Ki67, 23%.
Can we stop in the point of Ki, please? Our eminent pathologist, please help us. Excuse me. There is a difference in the specimen of the true cut and the result of the surgery. This is 11% and this is 23%. Dr. Maha, what we can do? Which one to depend and consider here high Ki or low Ki?
Actually, Ki testing is not standardized yet because of many pre-analytical and analytical conditions. Pre-analytical like fixation, specimen handling, analytical like we have many scoring system for analysis or assessment of Ki. In this case, I have an explanation that the expression is heterogeneous in that case. Sometimes Ki is heterogeneous expression. So the core diagnosed as 11 scoring percent, and after excision the scoring become 23%.
But we still depend on Ki in many conditions, and even new guidelines, even new trials, like Mark E may ask for the level of Ki to consider the patient high risk or low risk. Dr. Rida, please.
As regards this point, I have a comment comparing the result of the true cut Ki67 11% and the specimen after surgical excision. The patient took anesthesia and we did clamping of the vessels, did surgery. The lesion has been exposed to tissue ischemia for a long time. I would expect the Ki67 to be lower. But here it is 23%. So I will take the 23% as the index.
Yes, the 23 is a bit.
23 is the correct.
Correct.
Okay.
May I support Dr. Rida and Dr. Manal's words? In this case, the change is unexpected and quite strange. The lowering of the percentage could be explained by the pre-analytical fixation defects that usually happen with the surgical excision as compared to the core needle. But here we have the opposite occurring. So it is probably related to the abundance of the tissue. So we can see the heterogeneity, and we have many more average areas to cover. And so we would stick to not necessarily the higher value, but the value that reflects the more abundant tissue to examine.
So for us, now it is a high KI.
Actually, this is another point, because according to the KI 67 in breast cancer working group, the range before 5% should be considered as low, and the higher than 30 should be considered as high. And in between, because of the same factors that Dr. Manal raised, we still have some sort of gray zone. It is not that evidence or contrasting as a high KI 67 expression. There is some schools that assess the hotspots, others assess the average. This group finalized or established or validated the average rather than the hotspot. If we are talking about the same lab, then we should consider that the whole staff working in this lab apply the same score. This is also a point that we have, one of the caveats that we have to investigate. But at the end, we are moving in the range from 5 to 30. So actually, we are not strikingly a high proliferative index versus a strikingly low proliferative index.
She received 4 cycles EC, 12 weeks Taxol, post-operative radiotherapy, and started hormonal treatment tamoxifen. Should LHRH analog be added to the endocrine treatment?
I don't know. Dr. Sarah is still with us. Dr. Sarah still with us for this question? Okay. For this young lady, she is premenopause and she started tamoxifen. At that time, would you like to add LHRH analog for her? She is premenopause and positive lymph node, 2 positive lymph nodes. We cannot hear the voice. Sorry, we cannot hear you. I don't know if you can hear me or not, but we cannot hear your voice and your answer.
Oh, I'm sorry. Are
Yes,
you
now
able to?
we can hear you. We can hear you now. Okay.
Perfect. Thank you. So in someone who's premenopausal and who received chemotherapy for node-positive disease, I would think about ovarian suppression and potentially an aromatase inhibitor. You know, in the US, we would have sent an oncotype score on this particular patient. As was pointed out, we don't really utilize Ki67 given the challenges with reproducibility and validity of that assay. And so we would have sent an oncotype. Generally, if she had a high score, you know, clearly over 25, we would have given the TC chemotherapy. But it would have been more controversial if she had had a score less than 25. And so for people with, you know, scores between 16 and 25, it is a discussion with the patient, given that in our exponder, there was technically benefit to the chemotherapy. But in truth, I think much of that benefit may have been driven by suppression of ovarian function rather than true cytotoxic chemotherapy effects. And so I am usually discussing, you know, an alternative to chemotherapy being OSAI for those particular patients. But if, again, this was someone who elected to go ahead with chemotherapy, then I would have offered OSAI sequentially, assuming she retained menstrual cycles after that.
Okay, thank you. Please, Mariam.
According to soft antics trial, adding ovarian function suppression to tamoxifen significantly improved the disease-free survival with absolute benefit 4.2% at 8 years, and the clinical benefit was clear under age of 35. Also, adjuvant exemestane plus ovarian function suppression compared to with tamoxifen plus ovarian function suppression showed absolute improvement in disease-free survival and freedom from distant metastasis, 4% and 2% at 8 years respectively. If this patient is diagnosed in 2022, would the adjuvant treatment be changed?
Okay,
Can I have a question? Can I have a question about the role of hormonal treatment?
Okay.
For this patient, is it recommended to extend the treatment for 10 years about the tamoxifen, or should I think to give her, is it better to give her aromatase inhibitor with
the answer was in the previous slide regarding the soft text.
Oh, this is the question? Okay.
Okay. Yes. Our question now, even for all the audience, if this patient is diagnosed in 2022, we are positive, HER2 negative disease, and she has positive lymph node, she is 30 something, would you like to add something else in her adjuvant treatment besides the hormonal treatment? In other words, any role for CDK? Dr. Niveen,
Dr. Hani.
would you like to add
Dr. Hani, let me
CDK?
answer. Yes.
Okay, answer Dr. Niveen and then Dr. Hamzat. Would you like in this patient, if you have this patient nowadays, would you like to add CDK in the adjuvant for this one?
Yeah, I got it. Recently, we have the data about the Monarch 3, and in those cases who are high risk and they didn't achieve complete response, so we can give in the adjuvant setting.
She doesn't receive new adjuvant.
She didn't receive new adjuvant. Okay, so in the adjuvant setting, you can give this and you can add the Abema if it is available, and you can do it in the adjuvant setting, because as you know, still till now in our country, this is not the standard of care.
Dr. Muhammad Sabri.
Yes, I think this case, if I add grading to this case to be T2N1, you should have a third criteria of Monarch trial to have a grade 3 tumor to allow to give abemaciclib, keeping with Monarch trial. If you have N2 disease, you can go directly for abemaciclib addition. But with N1 disease, you should combine grade 3 or T tumor more than 5 centimeters to have the criteria either by FDA approval.
I totally agree with you.
To give abemaciclib.
Okay, please, Mariam. Can we see which group who get benefit of the Monarch
Please, Dr.
trial?
Hani.
Yes.
We want first to welcome Professor Gradisher, because he joined us, and we will just continue this case, and then he will present his presentation. Okay.
91% of the patient in Monarch E belong to cohort 1 with high-risk clinico-pathological features, N2 disease or N1 disease with tumor size more than or equal 5 centimeter or grade 3 disease.
So,
adding abemaciclib for 2 years to the adjuvant endocrine therapy resulted in improvement in invasive disease-free survival with absolute risk reduction 5.7% at 3 years.
So this patient have only 2 positive lymph nodes.
Yes.
She is grade 2. She is KI 23. I didn't think she applied for the people who get benefit of the Monarch trial, and I think there is no benefit. Okay.
Dr. Hani,
yes.
Can you ask about the role of this patient? She has BRCA positive, and can we give her, if there is any role for giving her PARP inhibitors as an adjuvant treatment?
This is coming in the last slide. Yeah, Dr. Iman, of course, in the next slide. Yes.
After 2.5 years of adjuvant tamoxifen without LHRH analog, the patient presented with suspicious ipsilateral axillary lymph nodes, the largest 2 times 1 centimeter, ipsilateral supraclavian lymph nodes 1.5 times 1 centimeter, bony lytic lesion at left iliac bone, dorsal and lumbar vertebral lytic lesions. Her performance status was 1. New biopsy and immunohistochemistry from the ipsilateral axillary lymph nodes, invasive ductal carcinoma grade 2, ER 7/8, PR 6/8, and HER2 plus 2, SESH was negative.
Okay, can we ask Dr. Sarah, it is a must to take a biopsy from the first metastatic site. It is a must, or it is better to have? Or unnecessary?
I think if it's accessible to biopsy, safely accessible, it should be a requirement. Because we are seeing more and more changes in receptor status upon recurrence. And so it is really quite critical. We know about 10 to 15% of patients lose ER upon recurrence. So understanding that, I think, is very critical. And in today's era, even understanding HER2 low, et cetera, it becomes quite important. So I am always rebiopsying upon recurrence.
Okay, Mariam, please.
The patient became metastatic. What is your recommended next step?
Okay, Dr. Iman. This patient is static after 2.5 years of tamoxifen single agent. She's still ER and PR positive.
And she has bone and what, sorry?
Bone, lymph nodes.
Axillary lymph nodes.
She is in good performance status, not in crisis.
I think I will give her CDK 4/6 with fulvestrant as a first line.
Which one? Which CDK? The common question, which CDK?
She is performance status, she is okay. The one with the best survival results, I will give her a ribo or a bema, both are good. And also, I think she is premenopausal, right?
Yes.
So I can give a bema because the trial show in patients with premenopausal, the 22% of the patients were premenopausal in this trial, yeah.
Okay, Mariam, what did she see?
The patient started the AI, gozerline, CDK4/6 inhibitor, ribociclib with denosumab every 4 weeks. She received palliative radiotherapy on the left iliac bone. According to Mona Lisa 7, the median overall survival was not reached in the ribociclib arm. With hazard ratio 0.7, the overall survival at 48 months was 60% and 50% with the ribociclib and placebo respectively. After 18 months of the anastrozole, gozerline, ribociclib, denosumab, her evaluation showed the progression with newly developed contralateral axillary lymph node and newly developed bony lytic lesion at the left scapula. What is your recommended next step?
Okay, now our patient received CDK inhibitor plus AI, and after 18 months, right, she developed progression. Our oncologist, what's your recommendation? Yes.
I think we don't have an exact answer for this. What is the next step recommended for the treatment of this patient? Because we have many options. We can go for BIK3 mutation status. If it's a mutant, we can go for abelacilib. If we don't have an access to the BI3 key, as in our case, we can recommend the everolimus and the hormonal treatment. And third option, and we have
the trial of everolimus was in post-menopause only, I think.
I know, but we can add the LHRH for the patient. And the third option, and we have now new data for, is the continuation of the CDK4/6 with the changing of the doublet hormonal treatment, AI go to fulvestrant according to the maintain trial, or the change the CDK4/6 to palbociclib. So we don't have the exact answer for the second line hormonal treatment. If the patient is the BRCA mutant, again, PARP inhibitor is still an option.
Okay, Maria, please.
The patient did genetic testing for PIK3CA mutation on the latest biopsy and was found mutant. According to SOLAR 1 study, the addition of alpelisib to fulvestrant
Can we see the slides, please? Can we see the slide? Yes. Back slide, Maria, please. Okay.
The addition of alpelisib to fulvestrant provided statistically significant PFS with hazard ratio 0.6.
Maria, excuse me, can go back for one slide?
Yes.
For one slide. Another one slide. Yes. Our patient had mutation on a liquid biopsy, and if Dr. Sarah, please, can you comment upon the use of liquid biopsy in the detection of PIK3CA mutation? Because many times we don't have tissue biopsy. Can we rely upon the liquid biopsy the same as tissue?
Yeah, no, it's an excellent question. I will say I do actually routinely get ctDNA analysis post CDK4/6 progression because I am trying to assess for PIK3CA mutation status, as well as, truthfully, I'd like to know ESR1 mutation status post progression on AI CDK as well. We do have data from SOLAR 1 where they have looked at outcomes both by tissue assessment of PIK3CA status as well as by ctDNA assessment, and both were predictive of benefit to alpelisib. And so I do think it's very reasonable to use ctDNA here for assessment.
Okay. Can I comment? PIK3 is a truncal mutation. If you have no site to biopsy, to take a solid biopsy, you can take it from archiving tissue in the lumpectomy surgery, because PIK3 is a truncal mutation. Didn't change, not an acquired like ESR1.
I'm talking about if the tissue is not available.
Yes, but it's available from surgery. You can test the biopsy from the lumpectomy 2 years ago.
Yeah, no, that's a very good point, that you're not usually seeing acquisition of PI3 kinase mutation. It's very low rate. They did see a couple in the Paloma 3 analysis, but it is very rare. And so I totally agree that if you had archival tissue and were able to assess it, it would be a good status assessment.
Okay. Go, Mari. Okay.
She started alpelisib with fulvestrant, gozerline, denosumab. After 2 weeks, her postprandial blood glucose 210 milligram per deciliter. She continued her treatments with adding metformin under supervision of endocrinologist. She received 3 months of treatment with evaluation showed stable disease, and she continued 3 more months with one dead CTE evaluation that revealed progression as regard the contralateral axillary lymph nodes and newly developed hepatic focal lesion at segment 5.
Now the patient progressed after 6 months of alpelisib. So the final and the last and maybe the most difficult question. Our patient still in performance 1. She is not in crisis. And she received 3 lines. And now, what is your recommendation? Next slide, please, Mary.
The patient performance is still ECOG 1. Here is some options: famtrastuzumab deruxtecan, PARP inhibitor if germline BRCA mutation, sacituzumab, chemotherapy, AKT inhibitor, capivasertib.
Don't forget that our patient in the second biopsy was HER2 plus 2. This was HER2 plus 2 in the second biopsy. In the first biopsy, she was HER2 plus 1. And can we consider her as a HER2 low patient? SISH was negative, yes, but she is plus 1 and plus 2. She is HER2 low. Can we consider her for the first option? The slide, please. Excuse me. The slide. نرجع back one اللي فيها الشويس. Yes. Regarding the comment of Dr. Imam Fuad, you asked about BRCA, germline BRCA mutation, and now BRCA mutation is considered. If the patient has germline BRCA mutation, we may consider PARP inhibitors, olaparib or talazoparib. SASI may be considered now for patient with non-HER2 positive. Any other line of chemotherapy, ACT inhibitors, we have new data. Okay. Dr. Sarah, what's your recommendation of if you have any other recommendation even?
I think if someone's progressed on upfront AI-CDK and then fulvestrant alpelisib, I would like to know if they had a germline BRCA mutation. If so, I would think about olaparib in this setting. If they did not have a BRCA mutation, I likely would offer capecitabine here. I think certainly the data with TDXD is very exciting and encouraging, but it was in patients who had had at least 1 prior line of chemotherapy and no more than 2. And so I'm usually offering TDXD in patients who progressed on first-line chemotherapy. So usually, for example, after capecitabine. So even though she is HER2 low, and I think TDXD would be an excellent option, I would prefer to use capecitabine up front and then go to TDXD subsequently.
In the coming few slides, we have some recent data and from slides from the last ESMO just 2 weeks ago. Please, Mariam, within half a minute.
Destiny 04 trial that included HER2 low metastatic breast cancer patients, hormone refractory, who progressed on 2 lines of chemotherapy, were randomized to receive famtrastuzumab versus chemo. There was improvement in overall survival in hormone receptor positive patients with hazard ratio 0.6. Median overall survival was 23 months versus 17 months. Olaparib Olympia D trial that included advanced breast cancer patients with germline BRCA mutation who progressed on endocrine treatment were randomized to receive olaparib versus chemo. There was improvement in PFS with hazard ratio 0.5. Tropics 2 trial that included metastatic hormone receptor positive HER2 negative cases who progressed on CDK4/6 inhibitor and at least 2 lines of chemo. There was a significant improvement in PFS with 34% reduction in the risk of disease progression or death with hazard ratio 0.6. Lastly, capivasertib, which is an AKT kinase inhibitor, was tested in phase 2 trial in combination with fulvestrant versus placebo in advanced hormone receptor positive breast cancer who progressed on previous aromatase inhibitor. The results showed that adding capivasertib to fulvestrant significantly improved progression-free survival with hazard ratio 0.5.
Okay, thank you, Mariam. And the last of this case, don't forget the patient with metastatic luminal A, especially not in crisis, in a good performance status, we have a hope for second, third, fourth, and maybe many lines, and of course we may have an impact of the overall survival. Thank you all of you, thanks to the panel, and thank you.
Dr. Hani.
Okay, thank you. And now for Professor Gradisher, welcome. And he will present a talk which is on the oligometastatic case, I think. Welcome, Professor Gradisher.
Thank you very much. And I think you have my recording, right?
Yeah. But first, I want to know, Professor Sarah is with us, or she?
I am here.
Okay. So you would like to continue with us?
I have to leave in 15 minutes, but I'm happy to stay for the next 15 minutes.
Okay. Thank you.
Thank you.
I'm very pleased to discuss oligometastatic breast cancer today, and I appreciate the opportunity by the organizers to speak at this meeting. And my panelists will elaborate on some of the points that I make, since the time is limited for this discussion. So let's go back to the case. This was a 37-year-old woman with a large left breast mass and palpable left axillary lymph nodes, demonstrated by both physical exam and imaging. She ultimately underwent a biopsy demonstrating ER/PR HER2 positive disease, and a PET-CT scan done showed hypermetabolic activity both locally in the breast and axilla, as well as in the 6th rib and C7, suggesting that there was metastatic disease present. Now, I think in order to level set everyone, we typically do not think of curing metastatic breast cancer. We know that there are long-term disease-free or progression-free survivals that occur. And many times when we see these exceptional responders, we think of the possibility of cure. And there is evidence that some of these patients do well for a very extended period of time. If you think about the lines of evidence suggesting metastatic breast cancer is curable, and this is from a paper that George Sledge published several years ago, we think about how we approach breast cancer in general, knowing that adjuvant therapy cures many patients that have very limited microscopic disease, micrometastatic disease. We know that even in the setting of a local regional recurrence, adjuvant therapy, both with systemic therapy, possibly local therapy, including both radiation and surgery, can cure patients. And there are long-term survivors who receive chemotherapy. And with newer agents that are available, we have exceptional responders, particularly those with HER2 positive disease. And there have been long-standing case series showing that in patients with low volume metastatic disease treated with surgery, radiation therapy, and systemic therapy, you can achieve long-term survival and possibly cure. Now, what I'm not going to do is show you the many series that have been published over the decades looking at patients who've had isolated lung mets, isolated liver mets, even brain mets, treated either with local therapy or local therapy plus systemic therapy. In all of these series, there's a suggestion that there may be patients who do very well when ablative surgery of some kind is done with or without radiation therapy as one of the modalities for treating these patients. So if we go back to some of those very early series, this is the MD Anderson experience published now 25 plus years ago, looking at over 1,000 patients who had metastatic disease treated with chemotherapy. And the point of this is not to really address oligometastatic disease, but to look at the tail on the curve of patients who achieved a complete remission. And in many of those patients, there was a long-term survival beyond 5 years, which is not typical. And of course, our goal is to try and figure out what is it about these patients that makes them different from the patients who don't do as well, who don't achieve a complete remission. If we focus on the patient at hand and think about HER2 positive disease, we see a dramatic improvement in outcome over the years with HER2-directed therapy. These are all patients with metastatic breast cancer going from 2008 all the way up through 2016. And of course, that doesn't even take into consideration some of the newer therapies we now have available, including trastuzumab deruxtecan, tucatinib, and other therapies. But you see a steady improvement in outcome. And although the most recent cohorts of patients haven't been followed long-term, it suggests they're doing better, and there may be a group that have very long-term survival. If one takes into account one of the most important trials of the last decade, the Cleopatra trial, which looked at dual HER2 therapy for metastatic breast cancer, now with long-term follow-up at basically 100 months since the last time it was published, we see that there is tail on the curve suggesting that some of these patients may have long-term survival. And for the group as a whole, as we appreciate, dual HER2 targeting confers a significant survival benefit. And if one takes into account those long-term survivors, of which there were roughly 100 compared to those who are non-long-term survivors, what are the characteristics that distinguish them? Often non-measurable disease, non-visceral disease, often bony disease or soft tissue disease, PR-positive disease, and a longer time from the additional diagnosis until metastatic disease develops. So these are characteristics on a clinical basis that may define which patients are likely to have a longer overall survival. Now, let's go to oligometastatic disease specifically. There have been many international consensus conferences that have attempted to define how we optimally treat patients with metastatic disease. The International Consensus for Advanced Breast Cancer met last year and readdressed this issue. And as you can see, oligometastatic disease is defined as low-volume metastatic disease with up to 5 lesions, and not necessarily in the same organ. And when assessing such a patient, it is viewed as being potentially amenable for local therapy, be that surgery or radiation therapy, rendering the patient in complete remission. Now, one of the important caveats, of course, is how we image patients to determine whether they have metastatic disease. As we come into an era where many people use PET and CT scans where it's available, you may be able to define more metastatic lesions, or you may be able to identify the patient who has very few lesions where you wouldn't have even known they were present before. And when we think about this, not unlike what George Sledge suggested earlier, these are patients with low volume disease that may be very sensitive to systemic therapy. And local regional treatments with systemic therapy may be potentially curative. But we always generally think of the systemic therapy as the first treatment initiated, and then consider local regional treatments based on the response of disease. And this was the collective consensus of panelists who participated in the Advanced Breast Cancer Consensus Conference last year. So more recent data, this from 2021, looks at survival of patients with de novo metastatic disease based on the number of lesions present. And perhaps it is of no surprise as you look at the number of sites of metastatic disease, the 10-year overall survival declines precipitously as we get into larger numbers of metastatic sites. And if you basically stratify as 3 lesions or more than 3 lesions, patients in this experience that was reported with over 3,000 patients suggested that, again, fewer sites of metastatic disease, in this case 3 or fewer, resulted in a better overall outcome, overall survival. So when we think about treatment options for patients, of course, this is the spectrum of disease we see. Early disease localized to the breast, more locally advanced, involving either bigger tumors or nodal involvement. The other extreme, of course, is disseminated metastatic disease. And then there's oligometastatic disease, where there may be disease in the breast or a situation where perhaps the disease in the breast has been taken care of at some earlier date. And then you have simply a couple of isolated metastases that show up. And the dilemma, of course, is how to treat these patients. When we think about very localized disease, above and beyond the local therapy, we consider systemic therapy based on the biology of the disease. Similar, although the intensity of the therapy may be increased when we have higher stage disease. And of course, when we get to metastatic disease, widely metastatic disease, we have a different approach, largely focused on systemic therapy. So the issue really becomes, what do we do with these patients with oligometastatic disease? Do we take into account systemic therapies that are used for earlier disease, or should we apply therapies that we more likely use in a more advanced disease setting? So what do we have as prospective data looking at management of patients with oligometastatic disease? As I already mentioned, there are numerous small retrospective cohort studies looking at surgery or of isolated mets in the liver or the lung, as well as the brain. There are similar experiences reported with radiation. And my colleague on the panel, Jonathan Strauss, who did an exceptional lecture on oligometastatic disease with a focus on radiation therapy, will have many comments as we get into the discussion. But we have a few randomized trials that help inform what we might think about using local therapy, and I'll talk about those. One surgery, the other stereotactic radiation therapy, the COMET study. So a study that my colleague at Northwestern, Seema Khan, directed and published is the ASUICOC 2108 trial. There have been many trials conducted asking the question of the role of surgery in patients with de novo metastatic disease. And this is the most recent. And for patients with de novo metastatic disease, they receive systemic therapy, whatever was viewed as optimal. And if there was no evidence of disease progression, metastatic sites in 4 to 8 months following the initiation of therapy, they would go on to the continuation of systemic therapy alone, or they would receive local therapy and then consideration of radiation therapy, any additional systemic therapy. And what this trial demonstrated, as many other trials in this setting have shown, is that there was no difference in overall survival, whether you did local therapy or not. And what was demonstrated, and others have shown this as well, is that you may reduce the risk of local recurrence if you do local therapy. But importantly, in this study, there were only a tiny fraction of patients who had oligometastatic disease as we defined it. So this was a very small group. Similarly, the experience with stereotactic radiation therapy, which Professor Strauss is going to talk about, has been looked at in a number of different small experiences that included a variety of diseases. The SABRE-COMET trial randomized patients to standard of care, which was palliative therapy versus standard of care plus radiation therapy to metastatic sites. And again, oligometastatic disease was defined as up to 5 sites of disease. But only 20% of the patients in this experience had breast cancer. But there was a suggestion that if you use SABRE-RT, stereotactic radiation, that overall survival was improved, as was progression-free survival. But as pointed out at the ABC Consensus Conference, there were only 18 patients in this trial that had breast cancer. So again, SABRE or stereotactic radiation therapy can be considered, but we do need confirmatory trials before this can go forward as a standard of care. There have also been other experiences more recently reported looking at the addition of local regional therapy and systemic therapy. This was an experience from Asia with about 1,200 patients from China, Korea, and Japan, where patients received various therapies for oligometastatic disease. Local regional therapy followed by systemic therapy followed by local regional therapy, or systemic therapy alone. And if you look at the 5-year overall survival, the addition of local regional therapies seemed to improve survival, 60% versus 42%. Patients with hormone receptor positive disease tended to do better, whether they were HER2 positive or not. Not surprisingly, as you looked at patients that had more sites of disease, the overall survival fell off. And the longer the duration from the time of initial surgery until the development of metastatic disease, oligometastatic disease, the better the survival. So again, there are hints that local regional therapy for patients with oligometastatic disease may impact on outcome. And then finally, as we go forward, it's not only the combination of these therapies that may be important, but actually understanding the biology of the disease. And we know from a number of different experiences that have been reported, this one now a little bit old, but there have been others that have shown similar results, that we tend to see a difference in some cases between the molecular makeup of sites of metastatic disease compared to the primary. And furthermore, there may be differences between the sites of metastatic disease themselves with respect to the underlying drivers, the mutations that are present. And this may in turn impact on therapeutic strategies that we employ going forward. So as we know, certainly in the estrogen receptor positive cohort of patients, it's very common to have obviously ER expression, and PI3 kinase mutations are present in about 40% of patients. And these are viewed as truncal mutations present from the beginning. And even metastatic disease, the fraction of patients with PI3 kinase mutation stays about the same. But under pressure of endocrine therapy, we see the emergence of ESR mutations. So there can be changes that accumulate as time goes by and metastatic disease presents. And as suggested in this sort of evolutionary pathway, even among metastases, there can be differences. So it may come that we will have to further define and refine our approaches to patients with oligometastatic disease above and beyond the simple tools that we currently have. So with that, I'll conclude, and I look forward to the discussion during the panel. Thank you.
Thank you, Professor Bradsher, for these elegant presentations that cover everything about the oligometastasis. But I want to ask you about the number of the metastasis to define the oligo, because there is difference in the curves, 3 or less or 5 or less, from your opinion, to consider it an oligometastatic disease.
Well, in my own mind, the fewer that are present, the better the likelihood that you'll catch them. Definition is 5.
Definition is 5. Okay, now Dr. Hagar El-Ghazawi will present us this topic in the form of case. So please, Hagar.
Thank you, Dr. Khalid. I'm pleased today to represent this case about oligometastatic disease in breast cancer. I think we face this. Okay. Thank you. I think we face this case frequently in our daily practice. So our case today is about oligometastatic case. Where always the question is whether to treat the patient as in a curative intent or a palliative intent or a midway. Unfortunately, we don't have a level 1 evidence for recommendations for these cases, nor a well-designed randomized controlled trials to address those patients specifically. On the other side, the ESMO Metastatic Breast Cancer Living Guidelines this year has proposed a new guidelines, and beside including the 3 biological subtypes, the ER positive and the HER2 positive and triple negative, they proposed a third or another category of the oligometastatic disease, which they specified specific points for the management of those disease. Patients with suspicious of the oligometastatic disease, a biopsy confirmation when appropriate is advised, and they advised for PET-CT scan preferred. And when a diagnosis of oligometastatic disease is approached, a multi-MTD discussion is highly recommended and with informed discussion with the patient. Also, they consider here the management of the primary tumor and axilla in a patients with the synchronous oligometastatic disease. They mean the synchronous oligometastatic disease, the patients with de novo oligometastatic disease, not the recurrent one. Also, they consider systemic treatment as a first approach, and they consider local treatment for the metastatic sites. Actually, this is not the only recommendations for the oligometastatic disease, but also in the MD Anderson guidelines, last recommendations in 2020, they advised that in selected patients with oligometastatic disease, excellent response to systemic therapy and acceptable performance status, surgery of the primary tumor and nodal involvement may be considered to achieve no evidence of disease. So they here aimed to achieve the no evidence of disease status, and definitive management of the oligometastatic site is also recommended. But the question here, who are those selected patients? So back to our case is a 37 years old female patient. She is married with 1 child and premenopausal and positive family history. And she was presented since last Feb, complaining of left breast lump of 2-month duration. On examination, there was a left mobile hard breast mass 5 by 3 centimeters in the upper outer quadrant and left mobile axillary lymph node 2 centimeters. Otherwise, she was free. The bilateral sonomammography showed the left breast mass by RIS5 in the upper outer quadrant with intraductal extension till the retroareolar region. 4.5 by 3 centimeters with pathological axillary lymph nodes in level 1, 2, and 3. The true cut biopsy of the breast mass showed invasive duct carcinoma grade 2 with ER/PR 8/8 and HER2 +3. She was staged as local staging for her as left clinically T2 and 3. The PET-CT was done showing hypermetabolic left breast mass in the upper outer quadrant extending to the retroareolar lesion with the size of 5 by 4 centimeters with SUV 13 and hypermetabolic left axillary lymph node and left supraclav with SUV 7 and 10 respectively, and hypermetabolic osseous lesion in the contralateral rib, 6th rib, and C7 and D2. So our patient was staged as clinical T2 and 3 M1 with triple positive and 37 years old. So our question, as you can see here in the photo, in the picture of the PET, you can see the breast mass and the axillary lymph node and the contralateral lesion in the rib and the C7 and D2 lesions. So my question to the panel here, would you consider, if you have any insights for the management of this patient? Dr. Amin.
I think the patients with oligometastatic disease should be treated within an MDT.
Yes.
Because if I want to treat these patients systemically, and then I want to be sure that the radiotherapy would agree to go for the ablative treatment of the bone metastasis. So if the MDT agreed for this young patient with triple positive, we have a target therapy with long-term survival, even with the metastatic disease, extensive metastatic disease, and having only 3 sites of the bone metastasis, I would go for upfront systemic, and then according to the response, we can decide further for the local treatment.
Thank you, but the question for the Professor Gradisher, would you consider this is oligometastasis or polymetastatic? We have C7 right trip and locally advanced triple positive disease in S3. So what your opinion?
Well, by the strictest definition, this patient probably does have oligometastatic disease just based on the imaging. However, not unlike what your colleague suggested, I would be more inclined to think of this patient from a therapeutic standpoint as having metastatic disease and treat her that way initially. And then if found to have a remarkable response in some of those sites that light up on PET scan, then I think we can revert to thinking about her more in the oligometastatic, as an oligometastatic patient, where a discussion about local therapy can be proposed. So I'd be interested to hear what others, including Professor Strauss, think about that.
So
If
to continue,
you please,
yes.
Professor Dr. Jonathan, he is still with us. Maybe I have a question concerning the stereotactic radiotherapy. What do you think?
Well, you know, we have a bit of a challenge here, which is that we have a histology agnostic trial, which shows a benefit for SBRT in the oligometastatic setting. But we now have the presentation of BR002, which is our first trial of SBRT for oligomets exclusively in breast cancer. And that showed no benefit to adding SBRT to standard of care systemic therapy. Meanwhile, we do have a whole series of other trials that are pending and that are hopefully going to add to that knowledge base. But for now, I would say we really don't have a lot to go on data-wise to show that we benefit this patient by treating non-symptomatic lesions up front. I think where things get a little more compelling for me is if we have a systemic therapy working very well, and we have 1 or 2 sites of oligoprogressive disease, that treating those with the goal of maintaining a great systemic therapy maybe makes more sense. But for this patient, I'm not eager to jump in with local therapy until we have better data.
So we will continue, Hagar.
Okay. So concerning that we do not have a typical data or very precise data for the oligometastatic disease, all we have from the literature, as we all know, the few prospective trials discussing or evaluating the role of locoregional treatment in metastatic breast cancer, not oligometastatic disease specifically. And these data was these studies was very heterogeneous in its methodology, and none of them had overall survival benefit, and they didn't include the advancement in the systemic therapy as the CDK4/6 inhibitors or the dual blockade or any other anti-HER2 therapies. So for the definition of the oligometastatic disease, as Professor Gradisher has nicely elaborated, that the ESMO guidelines specify them that to 5, but this definition is refined recently in this prospective study, recently published in 2021, that in a prospective registry, including more than 3,000 patients, the patients with 3 or less metastases has better overall survival, significant overall survival compared with the patients with more metastases. And in the multivariable analysis of this study, the patients who are presented with oligometastatic disease with less than 3 sites, the patients with premenopausal patients or no lung metastasis or local therapy to the primary tumor or local therapy to the metastatic sites has statistically significant benefit in the overall survival versus patients who did not. And also we have the data from the Cleopatra trial that with the advancements of the anti-HER2 treatment for HER2 positive metastatic breast cancer patients, we can see here in the curve, as Dr. William Gretcher also presented, that patients who received the Herceptin or the trastuzumab in the metastatic setting, 23% has survived 8 years, and those who received the trastuzumab and pertuzumab has survived 37% of them had survived 8 years, which is very large or long-term survivors. So those patients with long-term responders were analyzed in the last update of the Cleopatra trial, and they were defined as those patients who has non-measurable disease, non-visceral disease, or ER-positive disease. What about other factors impacting the prognosis in HER2-positive metastatic breast cancer patients? Actually, the de novo HER2-positive metastatic patients did well versus the recurrent cases. In this retrospective study with more than 1,000 patients, the patients with de novo metastatic breast cancer HER2 have statistically significant overall survival compared to patients with recurrent disease. And also another factor is the no evidence of disease. Patients who achieved no evidence of disease had better progression-free and overall survival compared to patients with no evidence of disease. So the question to our panelists, which systemic therapy regimen would you start with?
So this is oligometastatic disease. Shall we consider it loco-regional or metastatic? Is there any difference as regard the systemic treatment?
Dr. Khalid, I think systemic treatment, no doubt, she will have a systemic treatment.
Yes, sure.
It's eventually.
Sure.
But the site of METs is critical. You can see the revised cervical bone METs. You can see it's very close to the cervical cord, as well as the dorsal C7, the dorsal 6. I think the lytic lesion is very close to the cord. I think I want to discuss with you the safety of SPRT in these sites, because it's not a bone. It's very close to the cord, just touching the cervical cord and dorsal cord.
This is very important point, but away from this, Dr. Sabri, consider it away from the spinal cord. Do you give the chance for neoadjuvant anti-HER2 or
M1,
just Herceptin alone? This is the question. Dual blockade for such a patient. Some of us consider it metastatic, no need. Some of us, no, we should give her the chance. Do you use
dual blockage? Is by Cleopatra trial is not an option. It's obligatory to have dual blockage in M1 disease, even was oligometastatic. And I think oligometastatic will not change the systemic control. It may be fine-tuning the local control.
Dr. Iman, Dr. Niveen, is there any comment for the regimen of the neoadjuvant in oligometastatic disease?
If we agree that we are treating this patient as if we are treating, primary treatment, so she has the right to take all her advantage and all her, giving her the best chance by this chemotherapy. But I want, if you please, to ask Professor Gradischer, what do they do in such case?
Yes, Dr. Gradischer.
So in this case, because the patient has more of a locally advanced breast cancer, forgetting about the potential metastatic sites, she's going to get dual HER2 targeting as an initial therapy, whether you call her metastatic disease or not. And quite frankly, the only difference in her systemic therapy is whether you feel you should add carboplatin or not. It's either going to be THP or TCHP for us. So I think the important thing is that we would recommend that she get dual HER2 targeting. And typically we would give a taxane with that.
Yes. So continue, Hagar.
Okay, so considering that in the Trifina trial, in the neoadjuvant setting, the TCHP, the PSR rates reached about 66%, and the NewSphere trial, the THP reached PCR a rate of 45%. So after discussing this case in the MDT, the patient was planned for TCHP for 6 cycles, then to be re-evaluated, considering her good prognostic indicators as she is young age, premenopausal, hormonal receptor positive, 3 only sites of metastasis, and bone-only disease. So we hoped for maximizing her chance of response and hopefully to achieve no evidence of disease. So after receiving 6 cycles of TCHP, the patient, the PET-CT, showed partial response of the previously noted left breast mass, 3 by 2 centimeters with SUV 4, and complete response of the axillary lymph nodes, supraclavicular lymph nodes, and CR of the osseous lesions in the rib and C7 and D2, as we can see here in this is the PET-CT before, and this is after. We cannot see the decrease in the size of the breast mass, and the axillary lymph nodes is not here yet, and complete response of the bony lesions. So any of the panel, would you consider local regional treatment in view of the CR of the metastasis, and when?
Yes, our surgeon. What about the role of surgery after partial response? Actually, the metastasis disappeared, but locally there is still residual in the breast. What the type of surgery? And do you want to start here surgery or wait for such oligometastatic disease?
Yes, as Dr. Hagar mentioned in her presentation in the beginning, we are aiming at, we have curative intent in this case, oligometastasis. So I will go for local surgery after achieving this complete response in the oligometastasis. I will go for surgery. We can do conservative surgery, resection with free margin, and axillary clearance.
So,
aiming at cure of the patient, because this is the primary site which will give other metastasis later on. You have to treat it. You have to do full surgical treatment.
So for the axillary dissection, is it this case is oligometastasis, so only local treatment and leave the axilla for the radiotherapy? What about our radiation oncologist opinion about the treatment of the axilla in such oligometastatic disease? Professor.
So, Dr. Jonathan, you are still with us?
No.
Absolutely. You know, I think there's a question about whether or not to follow this surgery with radiotherapy. Our trial work suggests that surgery upfront in this setting will reduce the chance of needing palliation down the road, although that chance is modest. Do we add with radiotherapy after surgery? I tend to do so in one circumstance. If we think the risk of something growing back after the surgery is so high in the short term that it just wouldn't make sense to operate alone. Otherwise, I don't know that it's so compelling to follow with radiotherapy. But having said that, if the axilla is not dissected and I were planning to treat, I would expect, in the absence of gross disease, to have pretty good control.
So another question for you, because as Dr. Sabri said, this metastasis was high risk for spinal cord compression, although complete response for the systemic therapy. What about the radiotherapy? Is it now or postponed?
The first thing I'll say is, you know, we have a nice safety trial that's published now, BR001. I think we can do this safely. But the second thing I'll say is, I don't think we probably need to. And in the presence of a radiographic complete response, I would wait and watch.
Dr. Khalid, I totally agree with this issue. But can I suggest that you can leave the patient for 6 months or 1 year on systemic control, then
Follow up.
doing a local control after, because I'm not agree to have a local control just achieving the first CR. The
So
patient
the
not
timing
maintaining-
can postpone
Yes.
the review.
Yes, after long
therapy.
stability on systemic control, you can do everything, as you know.
So for Dr. Iman Fuad, there is partial response for the MAS. Always we use the new adjuvant only for 6 or 8 courses. What is your opinion in such oligometastasis? Shall we continue chemotherapy before surgery or only enough 6 courses?
I am just thinking why should I do for her the surgery after only 6 cycles of chemotherapy? Why? And she is responding. Why not to continue chemotherapy for more time as new adjuvant, if I consider it as new adjuvant, to give her 8, 10 cycles if there is no, of course, if there is no toxicity. And if I reach for a complete response rather than a partial response for the primary, I don't know if there is guidelines about this area. Should I continue for more cycles to obtain more response? The patient is responding. Why not to continue and then to postpone treatment, local treatment, until I get the maximum response? Maybe she is responding if I give her 2 more cycles, if there is no toxicity. Then I will go for the local treatment. After that, I should, for my opinion, I will go to do surgery when I get the maximum response. Then I will continue here for treatment with Herceptin and pertuzumab, and I will continue this to get. I don't know the duration. Actually, how should I give the duration? Should I continue here for this treatment until I will get evidence of new progression? Because this is a metastatic disease, even if it looks like it is oligometastatic, but she is a metastatic patient. So I will continue here on the dual blockade until the patient will get, of course, if she is hormone receptor positive, I will give with her something for the hormone endocrine treatment.
Totally agree. For continuation of the treatment, maybe Hagar will continue. But the question for Dr. Gradisher, what about the number of the new adjuvant chemotherapy in oligometastatic disease? If not achieved the complete radiological response, is it 6 cycles is enough as local disease, or you can add more cycles?
So, I mean, when we think about neoadjuvant therapy, we're really thinking about local regional responses more than the metastatic disease. So in that situation, we would typically give no more than 6 cycles, but the point is well taken. If the patient's disease is melting away, yeah, maybe you'd continue beyond that point. But I think there is caution, because with a TCHP regimen, people are going to start getting, a patient's going to start getting pretty beat up, experiencing, not insignificant toxicity by the time they get to the 6th cycle. And I think you always have to keep goals in mind. What is your goal of doing this? Because, if it's you're not doing a breast conservation operation in this patient. She's going to get a mastectomy. So I would typically stop at 6 cycles with the chemotherapy. Perhaps the HP would continue after that and see if she continues to respond. But I think then you're going to have to make some decisions about local regional therapy. If you're, had an incredible response. Most patients like this don't have everything melt away, but if she's an exceptional responder, then, as Dr. Strauss said, you may be able to think about some of those other options.
Okay, so can we continue, Hagar?
So I think we will discuss with Dr. Strauss the role of local ablative radiotherapy after CR. He will discuss with us these studies. And final question, after achieving the no evidence of disease, would you consider anti-HER2 therapy discontinuation?
Yes, but we need Dr. Hani have a question, or? comment.
New data from the last ASCO 2022 about the study published in the last ASCO by, I think, Stephen
NRG.
about the addition of the local ablative therapy in the oligometastatic cases did not appear to get more benefit. So the recommendation was don't add, this is the point of debate, to add local stereotactic radiotherapy or not, didn't add any benefit. So the recommendation is go for systemic, and the addition of more localized ablative therapy didn't benefit anymore.
So this is in the guidelines or just one?
This is just in the study of the ASCO 2022, just about 3 or 4 months ago.
Study.
This study is very powerful, Dr. Khaled.
Yes.
It discussed, and it was breast cancer patient-specific cohort. So it is very convenient or to take its
So postpone the...
No benefit, progression-free or overall survival from taking the SBRT or local ablative therapy to the metastatic sites. And I'll guess Dr. Struss will give us a note about this controversial
Yes,
results.
because some studies have an overall benefit for
This
local
is the last
region.
one, which was
Yes.
discussed
Yes.
in the last ESMO 2 weeks ago, and I think he will mention.
Yes.
اللي هي COMET study, phase 2 study, but it was not breast cancer specific cohort. And they gained overall survival benefit from adding the SBRT, but our cases out of those 2 studies, our patient has CR in the bone. So you will not add a benefit from adding, as Dr. Hani mentioned, from no benefit from adding the radiotherapy.
So maybe breast is different from colorectal or prostate. We need to know the radiation oncologist opinion as regard to the loco-regional treatment.
I think Dr. Struss can give us a hint about the 2 studies and the
Yes.
results and your preference to add the radiotherapy or not.
Sure. I'd be glad to, and I'll just kind of reiterate, I completely agree that the SABRE Comet looked really promising for adding SBRT in the setting of oligometastases, but it was both a small trial and had relatively few patients with breast cancer. And the question is, does breast cancer act the same as some of these other histologies? And we now have a couple of trials that have presented or published. One is BR002, which is treating oligometastatic disease and breast cancer, which, although it showed a local control benefit, failed to show any overall survival or disease progression-free survival advantage in the setting of oligometastatic disease. And we also have what's called the CURB trial, which looked at SBRT in the setting of oligoprogressive disease. And the CURB trial enrolled both patients with non-small cell lung cancer and breast cancer. And although an SBRT approach in the oligoprogressive setting appeared to work quite well, in fact, in non-small cell lung cancer, it did not appear to work in breast cancer. Now, having said that, we have a host of trials that are continuing to accrue patients, some of them breast cancer specific, and some of them histology agnostic, but enrolling larger numbers of patients. And I think as these come out, we'll continue to learn more. However, these trials tend to duplicate each other. They tend to give us the same answer, which is on the whole favorable for us in making decisions, but should lead us with a rather guarded expectations for what we're going to find in breast cancer.
So continue, Hagar.
So this is our final question. After achieving the new evidence of disease, would you consider the anti-HER2 therapy discontinuation at any point?
Yes, for Dr. Sabri.
I am not agree to discontinue anti-HER2 because you are controlling the tumor by blocking the HER2 pathway. If you are relieving this control, the recurrence will be there. So in the first slide, you mentioned in the ESMO guidelines, in the last part of the slides, all patients should continue systemic control, keeping with M1 disease. So it's new. It's not a new adjuvant. It's not M0. It's M1 and controlled by anti-HER2 by dual blockage. You can de-escalate and give single blockage if you can, but to omit anti-HER2 is not recommended at all.
So I think we all agree that we don't have, this is a very tiny studies, about 30 patients in each, and showing that the time prior to discontinuation or to consider discontinuation of the NCR2 was, the least one was 6 months from achieving CR. So after achieving CR, they waited for 6 months, they then stopped the trastuzumab, and the median time till progression with the least was about 1 year or more, 15 months, and another study reached 51 months. But this is very tiny studies we cannot rely on. But on the other side, the expert opinion in the ESMO guidelines, they mentioned that in patients achieving complete remission, the optimal duration of maintenance NCR2 therapy is unknown and needs to be balanced against toxicity, and stopping NCR2 therapy after several years of sustained complete remission may be considered. Thank you. I like to thank Dr. Mirna Ahmed, who helped me in preparing the case. And to thank Dr. William Gradisher, Dr. Strass, and Dr. Sima Khan, who she didn't attend, for their cooperation in preparing this session.
Okay, thank you for you, Hagar. I think for the element of time, no more questions.
Okay, so I want to thank all the panelists. I want to thank Dr. Sarah Tolani and also Professor Gradisher, Professor Jonathan, and I hope that we will meet physically next time, inshallah. Thank you all.
Bye-bye. Goodbye.